Hi, I'm SharonRoseCappella in Psychopharmacology with Dr. Michael Nishnikoff. Welcome to my presentation of Parkinson's disease, brain mechanisms, responsiveness to standard versus experimental treatments to attenuate progression, and prognosis. Parkinson's disease is a degenerative neurological disorder, second in prevalence to Alzheimer's disease, in which a dysfunction of the dopamine system in the brain causes a cascade effect of progressive symptoms throughout the brain and body. I have a vested interest in this topic as my brother suffers from early onset Parkinson's disease. He has had it for about 5 years since he was in his 50s. Currently defined by Australia's National Institute of Neurological Disorders and Stroke, Parkinson's disease is characterized as chronic, incurable, and progressively worsening due to its irreversible degeneration of the midbrain, specifically the substantia nigra, a region which produces dopamine projections that innervate or branch through the basal ganglia striatum areas that control muscle movement. Since dopamine projections consist of dopamine neurons, the brain cells which generate the neurotransmitter dopamine, a brain chemical whose purpose is to communicate the signal for movement from the brain to the body, degeneration of this system depletes dopamine, thus disrupting and deteriorating motor control, resulting in the characteristic tremors of Parkinson's disease. Symptoms of Parkinson's disease are extrapyramidal, meaning that they spread out from the pyramidal system of neurons which pass from the prefrontal cortex down the pyramidal tract of the brain and basal ganglia toward the extrapyramidal base of the brain, medulla, and spinal cord. Symptoms typically affect movement, especially in one arm or leg, and include lead pipe constant rigidity and painful muscles, especially shoulder, loss of fine motor control in one or both hands, arms stiffening to the sides and/or leg dragging during walking gait, ataxia, like a cogwheel mechanical motion, hunching over to facilitate walking, slowness of arm or leg movements, bradykinesia, landmark for diagnosis, reduction of voluntary movements, impairment of handwriting yielding small micrographia and shaky script, lack of facial expression, hypomimia, blinkless staring and drooling from loss of facial muscle control, swallowing difficulty, dysphagia, and soft-tone speech, hypophonia, both from motor dysfunction, and the signature Parkinsonism tremor of an arm, leg, or facial muscle affecting 80% of Parkinson's patients, low blood pressure, hypotension, constipation, loss of sense of smell, olfactory anosmia, tingling hands or feet, paresthesias, and muscle or nerve pain. Psychiatric symptoms include anxiety, depression, hallucinations, delusions, and eventually cognitive decline, potentially leading to dementia. Symptoms signaling potential Parkinsonism years in advance of disease include low blood pressure, orthostatic hypotension, gastrointestinal or urinary malfunction, sexual dysfunction, depression, anosmia, sleep disturbance, REM, rapid eye movement, behavioral disorder, restless leg syndrome, and inability to concentrate. Assessment of symptoms and quality of life are evaluated in 4 parts by the Movement Disorder Society Unified Parkinson's Disease Rating Scale, where Part 1 measures non-motor experiences, 2 measures motor experiences, 3 measures motor dysfunction, and 4 measures motor complications detrimentally impacting life functioning. Parkinson's 1.5 times more frequently afflicts men. Typical onset begins after age 60, but can occur as young as 20 in those genetically predisposed with an afflicted first-generation relative, and is the second most common neurodegenerative disease, affecting 1% of the world population. Diagnosis is made via blood test, CT computerized tomography, MRI, magnetic resonance imaging, PET, positron emissions tomography scan, or through a genetic test. Parkinson's is considered either genetic, as in 10% of cases, resulting from mutated genes, or idiopathic, its own disease, meaning of unknown origins, which accounts for its present incurability, since finding solutions requires defining the problem. The primary mechanism suspected in non-genetic Parkinsonism is Lewy bodies, proteins which form and clump in the brain, inhibiting synaptic signaling for communication, which first prevents smooth operation of the motor circuit, then cognition, memory, and behavior, as dopaminergic neuronal death spreads across the brain. Lewy bodies form by stockpiling improperly constructed alpha-synuclein proteins, synucleinopathy, which the body is incapable of incorporating or degrading. Kind of like collecting trash without throwing it out and then you can't move. These stockpiles damage cells in a phenomenon analogous to the deleterious effects of buildup of beta amyloid plaques and neurofibrillary tangles responsible for synaptic degradation in Alzheimer's and Huntington's diseases. New diagnostic tests search for alpha-synuclein proteins by cerebrospinal fluid via spinal tap or biopsying skin and nerve tissue. However, etiology, origin, of Parkinson's disease may be externally based in medications, toxins, encephalitis, inflammation, or brain injuries, and is linked to diabetes and cancer. British physician James Parkinson, in his Essay on the Shaking Palsy, described Parkinson's disease in 1817. The underlying cause of cellular deterioration in the dopaminergic system of the substantia nigra eludes most scientific approaches to uncovering a cause and thus finding a cure for Parkinson's disease, although current theories involve genetic polymorphisms and environmental toxins. However, there are immediate standard as well as long-term effective and alternative treatments either currently available or experimentally hopeful. Scientists correlate the present-day explosion of Parkinson-like disease to toxins, which exuded from the onset of the Industrial Revolution, while others correlate it to increasing advanced age in the population. However, the latter ratio does not account for a greater increase in cases than percentage of elderly persons. Elevated Parkinson's disease exists among manganese miners, and organochlorines, herbicides, pesticides, agricultural toxins, which inhibit mitochondrial function in cells and increase oxidation, including the death of nigrostriatal neurons, have been found in the idiopathic Parkinsonian brain. The present-day standard treatment for Parkinson's disease, used for over 50 years, is the pharmaceutical 3,4-dihydroxy-L-phenylalanine, better known as L-DOPA, generically levodopa, or amantadine. Both dopamine agonists, meaning that they facilitate the activation of dopamine at its receptors, which is key since Parkinson's results from loss of dopaminergic neurons. But since levodopa has a high tendency to react to the enzyme L-amino acid decarboxylase and transform to dopamine, which cannot cross the blood-brain barrier and so ironically is ineffective as treatment, carbidopa is a drug given in tandem with levodopa to prevent this transformation and thus enable levodopa to travel intact on large amino acid transporter 1 across the blood-brain barrier into the brain and serve as replacement dopamine. L-DOPA is highly effective in early-stage Parkinson's, especially 1 to 3 years into therapy, at alleviating motor symptoms, but decreasingly effective in later stages and comes with the price over time of inducing dyskinesia, involuntary muscle movements and shows evidence of activating the neurotransmitter glutamate in addition to its dopamine effect. According to Malik et al., responsiveness to L-DOPA in Parkinson's patients seems dependent upon age and severity of the motor function deterioration of their disease. In 1,007 cases of a median age 66.1 years, who were evaluated 3.4 years following initial diagnosis using the MDS Unified Parkinson's Disease Rating Scale Part 3 prior to and after morning administration of L-DOPA to determine whether their response was limited, less than 24.5% improvement, or definite, greater than 24.5% improvement, 61% of the cases, 614 patients, experienced a definite response, and 39%, 393 patients, experienced a limited response. So the ratio was nearly 2/3 in favor of a favorable response in the effectiveness of L-DOPA on early stage PD. This indicates the efficacy of L-DOPA for treating motor symptoms in earlier stages of Parkinson's disease. Since L-DOPA is a false neurotransmitter for dopamine agonist, meaning that it attaches as a ligand to the dopamine receptor to activate it, mimicking dopamine, L-DOPA functions as a limiting agent to the amount of dopamine released in the brain, by the brain itself, thereby preventing natural dopamine release in favor of L-DOPA. This fact provides a window not only into the mechanism by which L-DOPA treats Parkinson's disease, but also a potential flaw, which results in the body producing yet less natural dopamine due to the drug, in addition to that which has been destroyed by degeneration of the disease. L-DOPA dosing increases hit an eventual wall as the therapeutic index, toxic dose divided by effective dose, lowers. The body becomes tolerant. Other related treatments with limited effectiveness, either in early stages of the disease or to supplement L-DOPA, include dopamine agonists, dopamine metabolism blockers, levodopa metabolism inhibitors, and adenosine blockers. Non-dopaminergic receptor ligand therapies have been contemplated for potential capability of accentuating the L-DOPA effect. Evidenced by an 8-year longitudinal study of Parkinson's disease patients, subthalamic nucleus deep brain stimulation, formulated in the 1970s, is effective in treating advanced or treatment-resistant states of Parkinson's disease. Subthalamic nucleus deep brain stimulation is a surgery performed to implant electrodes, as the name suggests, beneath the thalamus, to stimulate the brain to produce more neurotransmitter, e.g. dopamine, not only alleviating Parkinsonism symptoms, but the pain and impulsivity associated with them, and induces synaptic connection, replacing the intentional scarring surgery once performed. Zhang et al. Conducted a study of 10 Parkinson's disease patients in southern China who were evaluated before and at 1, 3, 5, and 8-year intervals after undergoing subthalamic nucleus deep brain stimulation under the condition of on or off medication, L-DOPA, at time of procedure with the Unified Parkinson's Disease Rating Scale Part 3, and assessed quality of life with the Parkinson's Disease Questionnaire and sleep, emotional state, and cognition. Findings showed that of patients off L-DOPA, after 1 year, there was 50.9% improvement in motor function, 37.7% improved after 3 years, 36.7% after 5 years, and 37.3% after 8 years, whereas quality of life, which initially rose to 56.1% after 3 years, plummeted afterward. The study demonstrated the effectiveness of subthalamic nucleus deep brain stimulation in treating patients' motor function control for up to 8 years and maintaining quality of life for 3 years, mitigating disease progression, which ultimately became too advanced for treatment alleviation. Subthalamic nucleus deep brain stimulation is also effective in treating pain associated with Parkinson's disease, musculoskeletal dystonic, radicular neuropathic, and central pain. A September 2020 meta-analysis through PubMed, Embase, and Cochrane Library of 338 patients in 9 studies, including 2 randomized controlled trials and 7 studies involving observation, revealed, according to the Visual Analog Scale, Numerical Rating Scale, and Non-Motor Symptom Scale, a significant decrease, 0.83 median difference in pain following subthalamic nucleus deep brain stimulation versus control. Thus, subthalamic nucleus deep brain stimulation not only alleviates motor symptoms, but residual pain as well, thereby elevating quality of life. A third and potential cutting-edge treatment for PD, Parkinson's disease, based on favorable outcomes from animal studies, more limited in human studies, is the administration of antioxidant polyunsaturated fatty acids, omega-N3 fatty acids, based on new data that Parkinson's disease is caused by inflammation and oxidation of cells in the brain. These fatty acids consist cell membranes, assist the mitochondrial function of cells, both of which become eroded and deteriorated in Parkinson's disease, and can prevent neuroinflammation by limiting pro-inflammatory cytokine release by the immune system and protect astrocytes, brain cells which produce neurotrophins, the protective and growth-inducing cells in the brain, prevent sudden cell loss of apoptosis, and assist in both chemical and electrical signaling in the brain, thereby feeding the brain to be capable of normal signaling during neurotransmission, thus reducing the devastating effect of the neurodegeneration responsible for causing Parkinson's disease. Glimmers of hope emerge for patients with Parkinson's disease as experimental stage treatments show promise, including stem cell therapy, which introduces new cells that transform into dopaminergic neurons, neuronal repair therapy, and gene therapy, which repairs the mutated genes responsible for disease. CRISPR, clustered regularly interspaced short palindromic repeats, a sequence of virus-derived genetic coding used by bacteria with the Cas9 protein to fight disease on the DNA strand, is genome editing, perhaps the most dramatic current cutting-edge therapy to potentially eradicate neurological disorders such as Parkinson's, Huntington's, Alzheimer's, and ALS, amyotrophic lateral sclerosis. CRISPR-Cas9 takes advantage of DNA transcription to excise improperly formed genes, which yields unusable proteins. The subsequent deficiency of these proteins, Parkin, PINK, DJ1, LRRK2, responsible for cell regulation, differentiation, and survival, PARK8, and alpha-synuclein, programs early apoptosis, death to crucial dopaminergic glia and neurons, particularly in the substantia nigra, and the collection of unrecyclable alpha-synuclein, all of which are linked to triggering Parkinson's disease. By genetically engineering RNA, a copy of a section of half of the open zipper-like spiral of DNA, to fit complementarily against the section desired for excision, thereby removes the possibility that this gene can build faulty programming into the brain's computer, programming which sets off a chain reaction, eventually disabling its dopaminergic pathways. A healthy engineered gene can replace a faulty one using technological expertise to repair the damaged genome and reverse engineer the mechanisms of disease. The dawn of understanding origins of movement degenerating disorders comes through a series of current breakthrough experiments conducted by Johns Hopkins Medicine on mice, genetically engineered such that certain brain regions are selectively optogenetically silenced, to allow scientists to isolate the specific regions responsible for controlling, sequencing, planning, and recalculating movement. The experiments revealed in a series of licking and reward tasks performed by mice, in which they first learned fixed choreographed sequences, dancing mice, and then learned to adapt to disruptions in those sequences, that the premotor cortex controls planned sequences of movement, whereas the primary motor and primary somatosensory cortices control spontaneous movement. Connectivity in pathways among these regions, enabling complex chain of command links between movements from sensation to motion, determines the brain's communicative efficiency and ability to cope with change. This illuminates the mechanisms of effective brain wiring against which to measure the maladaptations that lead to defective wiring fraught the Parkinson's diseased brain. Life expectancy in Parkinson's disease, even devoid stable treatment or cure, has risen by 55% since 1967 to 14 and a half years following onset of disease. As we stand on the cusp of systemic understanding of the brain, its degeneration, and regenerative capabilities, hope for a future without Parkinson's disease exists within reason, within revision, and within reach. Thank you.